I think the other neat thing that has reemerged here at this meeting is that the ACC put together a consensus document and had a group to look at the use of non-statin therapies and when to add them to statins or when to use them in general. And a very well done and thoughtful document where it emphasizes the standing guidelines do the high-risk group and getting statins going as the base therapy, but then brought back the term of threshold. If you're above a threshold, that you then would think about adding a non-statin therapy. So for patients with atherosclerotic cardiovascular disease, with lower risk patients like that, they set 100 as their threshold, but for any comorbidity with diabetes, kidney disease, other risk factors, recent coronary event, that if you're above 70, that's when you want to try and think about adding on a non-statin therapy. And so they avoided the word target because that became very charged, but brought back the notion that you start the statin, check the LDL, and if it's not where you'd like it and not optimal, then you add non-statin therapies on top. And amongst those therapies, ezetimibe, they noted, was proven to have cardiovascular benefit, and PCSK9 inhibitors also is a very potent option to get LDL down. So I think there was a great sense of relief that we have numbers to work with again. We've actually been doing it. I heard data that the number of LDL, cholesterol panels done nationwide has been stable, despite the initial call that you don't have to, that physicians have been checking. And now we have a pretty good guidance that's very evidence-based on when to start thinking of adding on the therapies to optimize outcomes. So new data, new consensus documents to help guide therapy. So some real progress, I think, in lipid management here at ACC. Well, I think this is a helpful document in that there was a lot of confusion with the 2013 guideline that suddenly declared no treat to target and really ran counter to everything we've done for decades. This brings back the notion of checking LDL and adding therapies because there's been new evidence since that guideline. So that I think there developed some inertia out of that confusion that people weren't really changing much and were saying, what do we do and what should we do? This gives a nice evidence-based path forward to say, yes, we should be starting good therapies, but then monitoring and intensifying as needed to try and optimize outcomes. So I'm hopeful that this will give a backstop, really, and an encouragement to use the therapies that we have and try and make our patients' outcomes better. This consensus statement that the ACC put out involves discussion with the patient all over the document. And so this is front and center, that the factors to consider and to review with the patient of here are the things we want to try and avoid, here are things that increase your risk that make us think we really should be pushing lower, here are the potential side effects of this therapy, and coming to a joint decision so that it's not just the doctor but also the patient who are involved in deciding what can be the optimal therapy for reducing their cardiovascular risk. The field's moving rapidly. I think it's nice that we do now have something to talk about adding on the new therapies, and it's in response to new data since that guideline. And the notion of having a more rapid cycle for guideline updates is often talked about, and that's trying to speed up and keep pace with the evidence. So sometimes there are more targeted updates that come out, and this is indeed a targeted discussion on, on non-statin therapy. So hopefully we'll have the guidelines keep pace better with the evidence as it evolves. Well, I think the notion of when to turn to PCSK9 inhibitors, we've now got this document to help re-bring LDL levels into the discussion. So I think we are further along with this document as a helpful guide. We don't have the large clinical outcomes trial, and so it really is a controlling LDL therapy. But we have a mass of data about LDL and good outcomes that have been seen with statins and ezetimibe to buttress that approach. So I think we are starting to see more movement. I think also trying to figure out what interface with insurance coverage and how to actually do this, that it does take some time to figure out the paperwork or the processes, and so that's a key part of healthcare practice as well, and that's been evolving, I think, as well. I think we're sorting out who should get it, and so little by little trying to make sure that we've used the appropriate oral therapies first. I think there's always a struggle. It is an expensive class of drugs, and so the insurers want to make sure that it's an appropriate patient as well, and so there is often a review of the medical chart to make sure that it's appropriate. But I've been happy to see the patients that I've tried to put into the system have made it through, and so there has been access to this therapy. I think we're afraid, but so far, it takes a little bit of time and careful review, which, is appropriate, but it has been going reasonably well. It's a rapidly moving field, and so you never know what comes next. We have seen new data here at this meeting about statin intolerance, and finding also that some people can in fact tolerate statins, but that that this is an appropriate therapy and class of therapies for those who can't, when you clearly document. And so firming up the pathway of how to double check that someone does or doesn't have statin intolerance, and then moving to the next step, I think that we have some good clarity on exactly how to go through a thoughtful, evidence-based pathway for patients that have had complaints. So I think that's an important group of patients that there are a lot of, and there's some people with partial statin intolerance. So that's an area that I think will continue to evolve over the coming year. Whether we'll have outcomes data, I don't think in the next year, unless there are some surprises, but soon thereafter we may have the start of data from the clinical outcomes trial, which will certainly be a very exciting time in the field.